First of all, I wanted to thank Joe and the team at Thrombosis UK and Catherine, Julia, for inviting me to present today. And my background, as Julia has just said, is I'm a practicing anticoagulation pharmacist down in London at King's College Hospital. So my research and my interest in this area really stems from the patients that I see in our anticoagulation clinic at King's. So that's kind of why I'm interested in this and why my research is particularly in this area. So thank you for inviting me to talk about one of my favourite topics. Okay, let's try and move the slide on. Okay, here we go. So there's been quite a lot happening in extremes of body weight and the direct oral anticoagulants, particularly with the guideline update in the summer of 2021 from the ISTH. So I'm going to give a brief background about why we're even talking about extremes of body weight and why does it matter when we're prescribing anticoagulants. Talk about that update to the guidance and how it came about, what drove that change, and talk about the particular research that's important in that area. And then I'm not going to be too heavy on pharmacokinetics at this time in the morning, but I'm going to talk about our population PK study that we did for rivaroxaban, which was included in that ISTH update. So I'm just going to go into a bit more detail about that and talk about how we did that study and the findings. And then at the end, I'm just going to close with what I think are the outstanding kind of research questions or where there's data missing in this area. And then we can have a chance for questions and discussion. So I'm just going to start with what extremes of body weight are we talking about, and these are kind of the lines drawn in the sand by the ISTH. Whenever I think of extremes of body weight, and I think this is maybe true for many, is when I think of extremes of body weight, you often sort of go to the higher end of the spectrum first. So you think about obesity and larger patients, heavier patients first. And when we're talking about anticoagulation with the direct oral anticoagulants, the line that the ISTH drew in the sand was 120 kilograms or a BMI over 40. And at the other end of the spectrum, lower body weight patients, so that's patients that are less than 50 kilograms. That's the line that the ISTH drew in the sand. And that's kind of thinking about a normal distribution of weight. They're reasonable lines in the sand to draw to think about our heavier patients and our lower body weight patients. I must say in practice that I'm very much, I think many would say that we'll use a weight because that's the piece of information that you have to hand rather than going the next step to have a BMI. But yeah, so I would most commonly be looking at weights rather than BMIs. But that BMI of 40 is really important when you're looking at the research, because often we use a BMI in the research just to stratify or group patients into these extremes. So this is what we're talking about: patients over 120 kilograms and patients less than 50 kilograms. So there are extremes. And so I'm going to just briefly put a bit of context in here about these growing populations of these patients at the extremes of body weight. So I had a little bit of a look at the government website in Scotland about obesity, and the picture is very much the same across the UK and in the West. Generally, obesity is increasing, and some of the figures are quite they're quite eye-opening, really, when you think that 28% of the adult population in Scotland are obese. And I think one of the most worrying things is when you look at our children. So this this sort of plot here on the right-hand side, this is boys and girls and the proportion that could be considered at a healthy weight range. And if you look there at the 12 to 15-year-olds, there's only 60% of those could be considered at a healthy weight. So it does make you worry about that we're going to be seeing increasing numbers of patients coming into our clinic who are at these higher weights, who we will need to, they will get VTE, and we will need to consider which anticoagulant we're going to be able to give these patients effectively. So obesity is increasing in prevalence, and it seems to be that it could be more of a problem in the future. So we will need to consider which anticoagulation we're going to give these patients in the future. And then on the other end of the spectrum, with the lower body weight patients, these patients that are typically low body weight, and I'm thinking about these patients that are less than 50 kilograms, are typically our older patients. So when you're in clinic and you're seeing patients that are less than 50 kilograms, you're thinking that they're typically an older patient, often with many comorbidities, renal impairment. And this aging population is going to mean that we're going to see, or we're likely to see, more of these low body weight patients. So in England in 2016, 2% of the population were over 85. And that's set to double by 2041. So again, we're going to be considering which anticoagulants can I give to these patients safely. And similarly, we are now seeing more DOAC use in the cancer population, because guidelines have changed. The NICE guidance changed in 2020 to consider DOACs for cancer-associated VTE. Of course, there are some exceptions to that, depending on the primary malignancy, but we are anticoagulating more patients with cancer who are a group which tend to be of a lower body weight. And one study in the US had 1 in 4 patients weighing less than 55 kilograms. So together, an aging population, and we're anticoagulating more of our cancer-associated VTE patients with direct oral anticoagulants. Together, we're going to see more patients coming through our clinic doors who we need to anticoagulate, and we need to think what we're going to give these patients safely. So just to go back to our normal distribution of weight in the population, I think we're going to see a shift here from that 120 kilograms moving to the right, so that we're seeing more and more patients around that 120 kilogram mark as patients are getting heavier. And that's what we see here in a histogram taken from a US study of approximately 51,000 patients treated in the US. So these are patients with VTE who are treated with DOAC or warfarin coming through the clinic doors. And what you see here is, here's the line for 120 kilograms. It's sitting about here, and actually the upper 5% is probably more around the kind of 140 kilogram mark. So there's a sort of a shift of patients getting heavier. And I'd say from my own experience, it's not unusual at all to have a patient that's over 120 kilograms, and in fact, I'd say perhaps 1 or 2 a week, really. So it's not really a special patient group. They're the patients that we see in the clinic a lot. And we see these patients frequently. So just to pick up on the key, so why does this matter for VTE and anticoagulating these patients? Well, first of all, obesity is an independent risk factor for VTE. So this study is a little bit old, but I think it's still important that obese patients are have a twofold greater risk compared to non-obese patients of DVT-P at least. And BMI has the greatest impact in those under 40 years. So a fivefold, the relative risk is 5.2, 5.2 again for DVT and PE. So that risk is greater again in younger patients who are obese of having a VTE event. So we know it's an independent risk factor, so patients who are obese are more likely to have VTE. We know that the frequency of these patients is increasing, so we're going to be asked this question more and more. And it matters when we're anticoagulating patients because the consequences of undertreating and overtreating patients can be so serious. So for high body weight patients, we worry about under anticoagulation. So are we giving the patient enough treatment? And for low body weight patients, we worry that we're over anticoagulating. And this largely stems from traditional anticoagulants. And so we might think about low molecular weight heparins, and we use a dose adjustment based on weight. So we use milligram per kilogram doses and dose banding. So we're adjusting the dose accordingly as we're prescribing, or we're adjusting according to response. So when we're adjusting warfarin, we're looking at the INR. Typically, or quite often, we'll see a higher body weight patient will have a higher warfarin requirement to achieve a therapeutic INR. And for a lower body weight patient, they probably only need a very small dose. So we can adjust according to response. And the question comes in with the DOACs is because we don't make any of these adjustments. Apixaban, rivaroxaban, there's no adjustment for weight, and we give all of these patients the same dose. And then you worry, am I going to overdo it, or am I underdoing it? Am I preventing a recurrent DVT, PE, or am I increasing the risk of clinically significant bleeding? So these are the concerns. And then you think, okay, well, what did the DOAC studies say? What did the phase 3 studies back in 2012, 2013 say? Well, they didn't really have enough patients, or we don't think they had enough patients in those particular groups. And they also use different thresholds. So for example, if you wanted to draw comparisons perhaps between studies or pool the data together because you don't have enough patients, so you have to join the studies together to gain a better understanding. They've used different thresholds for their weights in the publications. Maybe they've used a BMI of 35. Maybe they haven't even reported that high threshold of BMI 35 for the safety and efficacy outcomes. Maybe they've used an upper weight limit of 100 kilograms or 90 kilograms, but those weights aren't unusual. In fact, you often see that sort of weight in the clinic, and that's not one of the highest sorts of weights that we see. So you can't really draw any conclusions from the phase 3 studies, and indeed the majority of the subgroup analyses. So you can't really take too much from the phase 3 data. And then you've got some primary, some PK data, some pharmacokinetic data about saying, oh, perhaps we're not getting as high peaks. Perhaps the area under the curve or the total exposure of the drug is a little bit lower in these obese patients, for example. So all of this together creates quite a bit, or did create quite a bit of uncertainty about prescribing these DOACs at the extremes of body weight. And as with anything, nothing's ever straightforward. Often it's not just a low body weight patient on their own. They've probably got renal impairment, they're probably elderly, they're probably on a number of other medications, they're fragile, maybe at risk of falls. So there's never just one thing. And our low body weight patient is often a very sort of complex individual. And a high body weight patient, when we're anticoagulating for VTE, younger age patients, women, heavy periods, that's a consideration. Then we've got the hyperfiltration aspect, and that's coming from the edoxaban data from the AF study, which is just confusing the picture a bit more. So it's never one problem on its own, and there's a few different aspects to consider. So I've just tried to put a little bit of a timeline in. So 2012, 2013, DOAC's licensed, off we go, no sort of specific thoughts on weight. The SPCs, so the product literature provided no additional sort of steer, no dose adjustment required for weight VTE, and I'm talking really there about rivaroxaban, apixaban, so no specific mention about weight. But then there started to be this growing uncertainty, this reflection on the phase 3 clinical trial data. Oh, wait a minute, do we have efficacy and safety data in this population? And then looking and thinking perhaps, oh, maybe we need a bit more reassurance from the pharmacokinetic kind of side. And in 2016, in response to this kind of discussion in the community, the ISTH put out its position to say to avoid the DOACs over 120 kilograms or BMI over 40, and then they expressed sort of, they highlighted patients less than 50 kilograms, but didn't issue any sort of real specific advice in this population. Then 2021 was the next iteration of that guidance, and there has been a sort of a balloon of data of experience after those phase 3 studies. So a really prescribing experience, and that's led to this change in guidance to suggest rivaroxaban and apixaban as options for patients over 120 or BMI over 40, but still no real guidance on what to do less than 50 kilograms. Interestingly, NICE gave some guidance in 2020, and they suggest if you are going to use a DOAC over 120 or less than 50 to use therapeutic drug monitoring, which is a whole other conversation. Maybe we can discuss that a bit more at the end. Certainly the ISTH has suggested to kind of avoid that routinely, but we can talk about that perhaps at the end. So I'm going to talk about the data that's driven that change between 2016 and 2021, talk about some of the pros and the cons, and hopefully you'll see where this has all come from. So I think there's two aspects that really the ISTH in 2016 wanted to see. They wanted to really see, okay, is there a difference between traditional therapy and DOACs for patients over 120 kilograms? Are patients having worse outcomes if they're on a DOAC? And are these high body weights, or are they about the same? So they wanted to see more clinical outcome data and looking at efficacy of the DOACs in these high body weights. And then they wanted to look at primary pharmacokinetic parameters to see whether they really are altered in high body weight. And if it's to a meaningful extent, if they're altered and it's only a little bit and it doesn't really matter clinically, then that's okay. But we just need to understand that, and that's what they wanted to look at. So I should say I'm going to start with high body weight first, and then I'm going to go and I'm going to look at outcome data, and then I'm going to move on to the PK data and then go on to the low body weight after that. So we're just going to focus on the high body weight data to begin with, and clinical outcomes. So this is a table taken from the ISTH publication, and I've just mentioned here that really there was very little that you could take from the phase 3 studies. There's some subgroup analyses and rivaroxaban to a greater extent than the others, but really you can't take too much from the phase 3 studies. Then they have sort of summarized here studies, retrospective, prospective studies, meta-analyses, and they're also including claims database studies here, looking at outcome data in these particular groups. And you'll see here that they've suggested that there are similar outcomes between apixaban and traditional therapy and rivaroxaban and traditional therapy in comparison with VKA. There isn't the outcome data for dabigatran and edoxaban, and I think that's going to be that's sort of one of the key messages really, is there just isn't the there isn't the experience in these with the other two DOACs, and there are perhaps good reasons for one, the lack of use with dabigatran, perhaps, but maybe for edoxaban just a lack of general data. But I'll touch on that towards the end. But I think what you see here generally, and this is a nice summary, is there's lots of outcome data for rivaroxaban, and there is some for apixaban. And that's the general message here from the ICH. But I'm just going to go into a few of the specific studies that have driven this. So we're going to start off in America, because the US obesity is very prevalent in the US. So it's a good place to look for patients who are being treated for VTE who fall into this patient group. And this, I'm probably going to pronounce this terribly, but Spira-Boulos study in 2019. So this is one of these claims database studies using insurance data. And it was a retrospective study, retrospective cohort study from two particular databases. And it covered the period 2011 to 2016. And patients needed to have an insurance claim code, if you like, for a VTE diagnosis, and then rivaroxaban or warfarin prescribed within a month. And interestingly, here they take the BMI from the ICD code, or the coding system. So I'll come back to that in just a moment. So if they had a code saying that this patient is morbidly obese, then if they had all three things, so a VTE diagnosis, a prescription for rivaroxaban or warfarin, and a BMI saying that they were morbidly obese, they were included in this study and followed for 12 months. And patients were matched, so propensity matched. So a patient on rivaroxaban and a patient on warfarin who were very similar to each other, and there's certain matching criteria, and they were followed for those 12 months just to see what happened. And there was no difference in the time to event analysis for VTE recurrence for the on-treatment analysis at 12 months. I think the recurrence rate here looks quite high, and perhaps that's as a consequences of the methodology of using these claims databases, not very sensitive to when patients stop treatment. So I think that's something just to be borne in mind. And as I say, just to think about that BMI taken from the coding system, well, BMI is dynamic. A patient may have lost weight, and that code still may be in situ for that patient, and they would have been included by accident. And equally, if they hadn't had that added, they would have been included in the study. So there are some limitations, but that from 2019, that paper was really important in sort of starting to get the outcome data needed and the experience. Also, quite interesting, less than 1% of the study population had a rivaroxaban plasma concentration taken. So people aren't monitoring, or weren't really monitoring, and levels weren't really being done in this population, despite it potentially being controversial. So people weren't really using that. Then going on to 2020, and another paper from the US, and this was Coons, and this is a slightly different. So this is a retrospective matched cohort study again, but this is using an integrated delivery system from 40 hospitals between 2011 and 2015. The primary outcome here again was recurrence of VTE within 12 months of the index events. But what I like about this study is that they've taken the diagnosis from the sort of claims codes, but they've used a weight. So they've looked for a weight between 100 to 300 kilograms as their inclusion criteria. And weight is what we typically use in the clinic rather than a BMI. So it's really nice to have that level of detail included. And they they again matched 2-to-1, 2 warfarin patients, 1 rivaroxaban, and at 1 DOAC, but 92% were rivaroxaban. So we're really looking at the picture of rivaroxaban here. And again, there was comparable rates of VTE recurrence, again, reassuring in comparison when compared to traditional therapy. So again, good news story coming out the US. They're using a lot of DOACs in this population. And in comparison to what the standard of traditional therapy, the outcomes are exactly the same. So this is really reassuring. The one thing about this study was the median weight was 115. So 50% of the weights were, I would say, maybe unremarkable here. And what we really want to look at is these higher weights, but half of the study is weights that aren't particularly high and of that real high interest group. So good study, interesting, but again, just want a bit more. And so in 2021, so this is a study coming from the Veterans Healthcare Association in the US. So 2013 to 2018. So again, looks in some ways a bit like a kind of similar study. And I found out a bit more about veterans health from a colleague at the university, actually. And I found it really interesting because naively, I assumed this was sort of limited to older adults, but that's really not the case. So this is paid for by the taxpayer in the US, and it's their way of looking after their servicemen and women and their spouses, and families. So you can access veterans health if you're 19, if you're a serviceman or woman. So, it's not limited to a certain group of people. It's anybody in the US who is linked to the services. And as my colleague was telling me, you've got your very old cohort who involved in the Vietnam conflict, but you've also got servicemen and women that went to Afghanistan, Iraq. So there's lots of she was sort of talking in these cohorts, and I found that really interesting. Anyway, I digress. What was great about this study is they have consecutively looked at patients presenting with VTE, treated with warfarin or any DOAC, and they looked at there was 51,000 patients. Those histograms I just drew on at the beginning of the presentation, and they had in total about 2,100 patients or so, over 140 kilograms, and that's that weight that we don't really have a great deal of information on. And 725 of those, so a third, were managed with a DOAC, the majority rivaroxaban. And again, in this high group, over 140 kilograms, the rates of VTE recurrence are comparable, really. So this is really reassuring data coming out of the US, and particularly in that much higher group that we haven't really seen yet. So this is really good. This was last year. So interesting data out of the US. So let's go a bit closer to home. So this is the first registry. So this is a study that I was responsible for in the UK. I say the UK, it was actually only in England. So there was 22 hospitals in England that recruited to this study, and we were looking at rivaroxaban for the treatment of acute VTE with no heparin bridging. So you couldn't have more than 48 hours of an injectable. And so we had just looking at time, I need to hurry up. So we had 22 hospitals recruiting about just under 100 patients that fell into this high body weight category. And what was really good was that actually it wasn't 1 or 2 hospitals that were prescribing in this subgroup. Actually, most of them were, and that was really reassuring, particularly as a single drug modality. So people weren't using a week, 2 weeks of a heparin lead-in or anything like that. They were going straight in with rivaroxaban in this group. For apixaban, there's not as much data at all, but what there is a big US claims database, 5 merged together, and there's 7,000 morbidly obese and apixaban patients. And to give some context, Amplify had around 5,500 patients in it overall. And then you look at this and you're looking at the population of interest and on apixaban. All of the outcome data is promising for apixaban, and you're seeing that kind of slightly more favourable bleeding profile coming through for apixaban. And it's really great to have that as an option when you're thinking about some of the complications that you can get with rivaroxaban, the heavy menstrual bleeding. And it's nice that you've got potentially another alternative DOAC that you could maybe consider before going towards warfarin or something like that. Edoxaban, we want more. So this is Etna VTE, big registry study across 8 European countries, about 2,000 patients, and they've just shared an abstract back in 2020, but the upper weight threshold that they used was 30, and 30, as I touched on at the beginning, that's not that's not particularly well, it is signifying that a patient's obese, but it's not really looking at these particular subgroups that we're really interested in to understand how many have you got that are higher body weights, and what is the safety and efficacy in those higher body weights. Where the BMI was over 30, the rates were comparable, and it did look okay, but we have to be mindful that they used an upper limit of 30. So this is all we've really got for edoxaban, bar some PKPD data coming from industry, but we just need a bit more from edoxaban. So population PK, so are the clearance of the PK parameters altered in high body weight? So we had to, we didn't have to. So we did a population pharmacokinetic model at King's College Hospital, and we did this from therapeutic drug monitoring data. So in the early days of the DOACs, we were very nervous about using this fixed dose and wanted to understand more about the levels. So we were routinely taking a rivaroxaban plasma concentration from all of our patients coming through. And from that data, we were able to derive a population PK model. So we put all of that information together, and we can generate like an equation, if you like, that calculates that predicts rivaroxaban concentration for a certain patient. And then with that equation, we can then simulate patient groups of interest, which I'm going to show you now. Well, after this slide, actually. So I just wanted to show you who we included. So we had 86 patients over 120 kilograms and 74 patients with a BMI over 40. We had a good number of patients with at least moderate renal impairment. And here we see on this plot over on this side here, the x-axis shows time after dose and weight is on the y-axis. And we can see here that we had a good amount of patients with a body weight over 120 kilograms, providing both peaks and troughs, but less so for low body weight patients. And with this data, you can see here the red lines, dashes indicate the range from the Einstein, or the 5th and the 95th centiles from some of the Einstein studies. And this is area under the curve, so total rivaroxaban exposure. And you can see from our study here that when you're at the higher body weights, that the median is overlaying all of the interquartile ranges. So this is really reassuring that this red line goes through all of these boxes. And you just see here where the body weight is a bit lower, that the overall exposure is a little bit higher, but again, generally falling within the 5th and 95th centiles of the Einstein study. So really, a high body weight's not having too much of an influence on the area under the curve. We're not seeing, it would be more worrying if these boxes, were really right down here in terms of exposure. On the other hand, renal function, so this is creatinine clearance less than 15 or 15 mils per minute, and then 50 mils per minute, 100 mils per minute, 130 mils per minute. And what we see here is a much more stepwise change in the area under the curve as renal function decreases. And I think you can see this perhaps a bit better on this plot with individual patients. So again, x-axis time after dose and concentration on the y-axis. And this is changing weight. So all of these patients are the same except for their weight. So here we can see that the trough concentrations are all very similar, and it's just the patient with the low body weight that's having that higher peak. But really, there's not too much difference according to body weight here in terms of the concentration profile. If we were to look over here to this plot, what we see here is changing creatinine clearance, and the patient in red has severe renal impairment, creatinine clearance of 15. And if we compare that to the blue line, which marks somebody with a creatinine clearance of 90, there's quite some difference, and we can see the difference in exposure there. And I think what you see here is the influence of weight on this side, not much, and the influence of renal function. So if there's something to be mindful of, it's renal function for rivaroxaban in terms of accumulation, rather than weight, which is, it appears to be having a very minor effect and not significant. So I've just summarised what I've just said there. I'm just going to move on in the interest of time, but rivaroxaban and apixaban are options because of the outcome data that I've just shared, but not limited to what I've just shared. Edoxaban, we just need more real world experience and outcome data, although there's concern about high creatinine clearance coming from the AF population, so that's a whole other conversation, I think. And dabigatran doesn't have favourable data in these high body weight patients. Yeah, so I think the main message is they're all different drugs, and you just need to consider really, yeah, they all have different pharmacokinetic properties, and they should be treated as such. That's what I think. So low body weight, it's kind of overlooked. ISTH wise, we see a lot of these patients, they do make you concerned when you see them in clinic. You think, oh, is this going to be okay for you? You're so small, renal impairment, old, maybe malignancy, and you worry about the safety of the DOACs in these populations. It's difficult to ascertain how many patients that were less than 50 kilograms. Again, same issue with the seminal phase 3 studies for the DOACs. Mostly they use a threshold of 60 kilograms. It depends where you look for this data. So if you were looking in Western registries, in the RETI registry, there's 3.5% with body weight less than 50. But over in Japan, they make up half of the VTE command registry, although that's largely traditional anticoagulation there rather than DOACs. And we know that these patients typically need, why this matters is because we know they typically need less anticoagulation, and we worry about safety outcomes. There's lots of information here. So I think the key points I would take away is, as part of bigger weight studies, where less than 60 kilogram patients have been included, what you see is more women, you see more renal impairment, and a higher proportion of cancer in these patients. And what we see here in terms of major bleeding in this cohort, comparing less than 60 with 60 to 120, is really quite a high rate of major bleeding in this group. Arguably, there's lots of other factors that could contribute to that, but they tend to fall in these patients with low body weight, and so we must be mindful of these patients. And again, that's echoed from the Veterans Health paper that I referred to from Perino et al. In 2021, that there is there looks to be a higher rate of bleeding in this population. So it's just we should be mindful of this, and we need more help in this area, I think. I read this the other day, and I didn't agree with it, and I just put my corrections here as to what I think it should say. So it's about a meta-analysis, and it said it concludes that DOACs are safe and effective in morbidly obese patients. And I would disagree, and I hope what I've shown here would make you agree with me that is rivaroxaban and to some extent apixaban are effective and safe in patients of high body weight or obesity. And again, not grouping the DOACs together. So not the DOACs, rivaroxaban and apixaban, not all of them. So in terms of thinking about guidelines and things like that, I think we just have to be really mindful about the nuances of the data that's out there. It's rivaroxaban and apixaban. It's not edoxaban and dabigatran, so they shouldn't be grouped together when we're talking about extremes of body weight. And then at the end, it mentioned a randomized control trial to confirm non-inferiority. This is really unlikely to happen. So yeah, that's it. And that's the summary. I'm aware that Julia's here and I've run out of time. So in summary, that's kind of what I've alluded to already. Yeah, and these are my sort of what I think we need to do, what we've got to do. Thank you.
Thank you very much, Victoria. That was really an excellent overview and very, very interesting and very topical and relevant. So that's fantastic. It is nearly 9:45, but I think we should have a little bit of time for questions, because at the end we don't have the 15-minute talk right at the end of the meeting. So we've got a little bit of time to discuss, and I think this would be helpful if that's okay.
Yeah.
Now, there's been some questions coming in as you were talking. One of the questions I think is from Abraham Song, is in relation to atrial fibrillation and extremes of body weight.
Yeah.
Is there any guidance for DOACs? No.
For the ISTH, SSC has notably not mentioned AF. So this is a problem. Yes. It's difficult because we see these patients all the time, and like I said, increasingly, and particularly in the AF population, these really low body weight patients, and you do worry about them. But no, there's not anything specific in AF. Our practice is to kind of apply the VTE guidance, but that's our practice at King's, and we are more cautious with patients over 150 kilograms because we don't believe that there's the same amount of data there. So yeah, so we apply the VTE data, but guideline wise there isn't a position on AF, which is a shame.
Okay, that's great. And then there's been a few comments and posts from Professor Cohen, which are very interesting. I'm not sure if we can actually get Professor Cohen on live to actually ask the questions. Joe, is that possible?
I'm going to try, just give me one moment.
Because he's got some very interesting comments.
Can I also ask, Victoria, could you possibly just stop sharing, then we can see everybody on the screen? Thank you.
What I'll do, Victoria, if you can still hear me, is just mention one of the posts from Professor Cohen, which was, how do you explain to high body weight patients who bleed on VKA the basis for the ISTH recommendation?
Who bleed on VKA?
Yeah, so on warfarin, I guess he's meaning. That was one of his questions.
Could I actually explain what I meant by that?
Yes, please. Yes. Thank you. We've got you on. Thank you.
Well, the first thing is I'm Dr. Cohen and not.
Oh, sorry.
That's all right. And the second thing is that, look, we had good evidence from over 2,000 patients that weighed over 100 kilograms in the phase 3 studies, that there was no loss of efficacy. And I know that wasn't covering the 120 kilograms, but there were subgroup analyses that looked at 120 kilograms or over 100 kilograms. And not only was there no loss of efficacy, but there were safety advantages. So the ISTH broke one of the rules of research. And the rule of research is lack of evidence doesn't mean that it doesn't work or it isn't safe. Lack of evidence or limited evidence means we need to get more evidence. So what they did was they shot from the hip and said, you know, based on theoretical things, and we all know how theoretical things are often proved wrong, as in this case. Based on theoretical, we shouldn't be using DOACs unless we measure levels. But they also said at the same time, there's no evidence that the levels give us any information. So my question is, how would you explain to a patient that was over 120 kilograms that you treated with a vitamin K antagonist and who bled? How could you say to them, well, I gave you the safest option when there was evidence for the contrary? I think that's a real danger of these speculative recommendations, and sadly they come a lot from, you know, people that like making guidelines.
Yeah, I fully agree with you, Dr. Cohen. Yeah, it's difficult to say that you've picked the safest option there, because you don't have the grounds to say that. I agree with you. Yeah.
When you say it's difficult, the safest option, there is good evidence from the phase 3 studies that people weighing over 120 kilograms do have a better safety profile in the randomized controlled trials, as well as the observational studies, than treating them with VKA. So it is the safest option.
Oh yeah, no, I agree with you. Yeah.
Yep.
Yeah, I think it would be a challenging conversation to have that, because knowing that information, that's what I meant.
See, I think this is a dangerous trend, but I have a question, something which I found very interesting in your study, Dr. Speed, and that was that the creatinine clearance, I wondered whether the higher bands of creatinine clearance could be used as a surrogate, like a new INR, to sort of get a feel for, you know, whether we're overexposing patients where you don't have the ability to measure levels.
So I'm not sure. I just want to make sure I've understood the question.
So you know how we use INR in vitamin K antagonists to get a feel for overexposure or underexposure.
Yeah.
So your data was particularly interesting, I think, in your publication, because you showed a correlation with decreasing creatinine clearance with increasing exposure. So my question to you is, could we recommend for the people with the higher bands of creatinine clearance that might be used as a surrogate for, like, what INR is to VKA is creatinine clearance?
Yeah, well, it's a really interesting point, because it was so when we added creatinine clearance in, it improved the fit of the model so well. There was such a strong correlation there between exposure and creatinine clearance. And I guess to some extent we're doing that in the AF population. Then there's a line drawn at 50 mils per minute, and that's how you do the dose adjustment. We don't do anything like that in VTE for rivaroxaban. But yeah, I think that's an interesting point.
I have another point, but there may be other people who want to go on. So well, I'll bow down unless you have time for another question.
Well, what I think we'll do, if it's okay, I've got 2 other posts which we'll ask Victoria, and then we'll move on to Elaine's. But thank you very much for your comments. That's really nice to hear from you. Colin Church has asked, what about the dose we should use? Should we ever reduce dose after 6 months? I'm assuming you're meaning, Colin, in obese patients. So would you do that dose reduction that's recommended by manufacturers if you're obese?
I don't know if there's I'm just trying to think what the SSC position said on that. I think it's difficult to say that, because if someone's obese, they still have a persistent risk factor for VTE. So I think that's something to think about. And I think the ISTH position says something specifically about that, which has just escaped me. But I think you'd have to think carefully about reducing the dose there.
Okay. And then final question from Dr. Venugopal, which is, what is the impact of cancer cachexia in patients with low body weight? Do we modify dose in a dynamic manner when their body weight improves? Good question.
So I think the dosing should be done according to the label, and whether you're using the 2.5. Sorry, so we're talking about VTE, aren't we? So I think you've got to be dosing according to label, really, and there's not the evidence to support going off label for the extremes of body weight. Yeah, it's a really difficult one because it's a really difficult group. Yeah, I think we would tend to go for a DOAC where we could use the lower dose. We might sort of err towards edoxaban, but yeah, it's tricky.
So, but Victoria, thank you very much. That was an excellent talk. We enjoyed it very much, and we're going to move on now. So thank you again for doing that for us.